Welcome, everybody. We're going to get started shortly. Thanks for joining. Look at all these names. Everybody came to see the best panel. I love that commercial. I think we have one more really quick and then we'll go ahead and get started. It's totally cheesy. Oh no, that's
Hey everybody, it's Callie Christensen, your 2021 Rev Cycle Roundup event chair. I am so excited to be with you today and be kicking off our second successful day after such a great day one. Thank you for joining us today. A special thank you to all of our generous sponsors that made this event possible for our provider and payer friends to attend at no charge, whether they're an HFMA member or not. So tip of the hat, not just to our region's annual sponsors, but to the event sponsors that stepped it up and afforded us their commitment today. I want to thank the Rev Cycle Roundup Committee and my Arizona chapter president, Samantha, who has been the single best president that anybody could ever ask for. You talk about grace under fire in the midst of a pandemic, an end of year and crazy budget stuff. And everybody said yes. They wanted to double down on their commitment, not just to their membership, but to the HFMA community, our families and friends that make HFMA such a great place to be. I have had the fortunate opportunity to be part of HFMA for the better part of 10 years through multiple regions and multiple states. And one thing that continues to be the case from no matter where you're joining us is through HFMA, we rise by lifting others. I have grown so much personally and professionally through the work that I've done through HFMA committees and events that I can't tell you what a blessing, privilege, and pleasure that it's been, and I bet it'll be that way for you too. So as we're knocking on the door of our next program year, I ask you to consider extending your reach and joining the journey through whichever way calls your name. So again, thank you so much. Without further ado, we're going to kick off today, and thanks for joining. We'll talk to you soon.
So that was horrible, right? I'm so sorry for the selfie, but I was afraid I'd get a case of the feels as we got started. You guys, we are so excited to kick off day two after what a successful panel we had yesterday with the CXO. Great feedback from the breakout sessions, and the networking fun was amazing. So everybody, thank you for joining us. I am so blessed to introduce this panel and my president, Mr. Scott Purcell, not just the president of Haas Group, but the president of our sister agency, the American Collectors Association. So he's worked very closely with me in putting this panel together. We have systems of all sizes represented from across the region. And with that, Scott, I'm going to turn it over to you, and thanks to the panel.
Thanks, Callie, and it's so good to be here with everyone today. And we do have an amazing panel, and that's what I like about HFMA and the HFMA family. It actually reminds me of pursuing my accounting degree in Beta Alpha Psi, the accounting group there. There's just so much passion, there's so much excitement, and it's because every one of us, everyone participating today, and especially everyone on the panel, shoulders so much responsibility, especially in the provider and the payer community, to help ensure we've got the best healthcare at the most affordable prices, and really are an integral part of how we serve every member of the communities that we live and work in. And what a great privilege to be able to take some time to sharpen the axe, if you will, to get even better. And I hope, even though we're in this virtual environment, I hope you still take advantage of the opportunity to meet people you've not met before, perhaps people in similar systems as yours or settings as yours, and really develop those friendships, develop those colleagues, to help you be the best you can be, accomplish your professional goals, but also have an opportunity to give back. And as we give back, we indeed make the world a much better place. So I am going to have each of our participants today. We're going to go in alphabetic order because that makes it fair and easy, right? To introduce themselves a little bit about their systems so you can understand the perspective that they're coming from and hopefully connect with them after this as well. So with that, Candace, let's start with you.
Candace, we cannot hear you. There you are.
There we go. Novice mistake. Hi, I'm Candace Hoshi. I'm the Vice President of Revenue Cycle at University of Colorado Health. We are a 12-hospital health system across the Colorado Front Range, serving both our academic research teaching mission and supporting many of our Colorado communities. We're just over a decade old as a health system, and we have a lot of differing flavors from an academic hospital, we have community hospitals, we have a sole community provider, we have a critical access hospital, freestanding ASCs, we've done mergers, acquisitions, new constructions, you name it. So we're really hoping to be a little bit of everything, and thanks for inviting me here. Happy to be here.
Thank you so much, Candace. Chris.
Hi, I'm Chris Ambrogi. I'm our Executive Director of Revenue Cycle at Kalispell Regional Healthcare. I'm also over reimbursement as well as managed care. Kalispell Regional Medical Center. So that's Kalispell, Montana. That's in the upper northwest corner of Montana, our crown jewel, we like to believe. We're a tiny system. We have an acute care facility with about 210 beds. It's a sole community hospital. We have a 100-bed SNF, skilled nursing facility. We also have a 25-bed critical access hospital in Whitefish, Montana, as well as about 40 clinics in our network as well. It's a pretty small town to serve. Where we like to believe we're huge here, but in comparison to others around the country, we know that's not true. But yeah, so super excited to be here. Lots of exciting things coming in the future from Kalispell Regional Healthcare. So keep your ears tuned.
Thanks so much, Chris. Connie.
Hi, Connie Perez, Vice President of Revenue Cycle for Phoenix Children's. Those of you who know us know that I may have in the past introduced us as Phoenix Children's Hospital. But one of the most important things about us right now is that not only are we the only freestanding children's hospital in the state of Arizona, we are now on a journey to become a health system. So we are in the process of building another hospital. There will be more to come after that. We already have about 1,000 employed physicians, and we are on a path for growth, not just in our subspecialists, but especially in the primary care world. So we kind of think about ourselves as a teenager. We've been in the new hospital for a little over 15 years, and are really on that journey to shift from hospital to health system. So glad to be here with all my HFMA friends. I know we all wish we could be together, but thanks so much for joining.
Thanks so much, Connie. Laura.
Yeah, good afternoon, everyone. I'm Laura Calkins. I'm the Vice President of the Revenue Cycle for Presbyterian Healthcare Services, which is headquartered in Albuquerque, New Mexico. Presbyterian is an integrated delivery and financing system. We are New Mexico's most preferred healthcare system, serving 900,000 New Mexicans across the state. We employ around 1,100 physicians and advanced practice clinicians in over 30 clinic locations and have 9 hospitals across the state of New Mexico. Our mission is we exist to improve the health of the patients, members, and communities that we serve. And to give you a little context for that, New Mexico has the highest percentage of population by Medicaid in the country at approximately 38%. Medicaid enrollment across the state has increased here almost 8% in just the 1 year of the pandemic. And New Mexico is #1 in poverty for residents over the age of 65. Unlike some of the others, we are a very well-established healthcare system and have been serving New Mexicans for over 100 years. Thank you, and I'm looking forward to today.
Thanks, Laura. Ray.
Good afternoon, everyone. I'm Ray Potter. I'm the Associate Vice President of Enterprise Revenue Cycle here at Wyoming Medical Center and Wyoming Health Medical Group. We're located in the heart of Wyoming, right here in Casper. We're the largest hospital in Wyoming with 2 campuses. We have 249 beds between those 2 campuses. We got 14 medical group clinics, and we also have an ambulance service. We're the regional trauma and referral center for Wyoming, and we serve just about 50% of the population here in Wyoming as well. In the spring and fall of 2020, we were actually awarded an A from Leapfrog Hospital Safety Grade. And in October of 2020, we affiliated with Banner Health, and we're currently going through a integration with them right now.
Thanks, Ray. And you can see for everyone participating, we have such a diverse group of presenters. So we should be able to get your questions answered, and you're going to get some really intriguing insights. I just want to say a personal thank you to each of you. Everybody is so crazy busy, and we did some preparation ahead of time, making sure the technology worked and being on the same page. And I know the effort it was in order to make the investment in Region 10's presentation today. And thanks each one of you. Well, let's get into the detailed questions. The very first one, as an industry, we're all observing really significant changes in the payer shift. Often that's resulting in higher patient personal pay balances. There's 2 aspects that we want to take a look at this. The first one is, what changes has your system or your hospital made to truly help patients understand their responsibilities, as well as helping them pay their bills? And Candace, if you're good with it, let's start with you.
Yeah, so this has been going on, I think we all know, for well more than a decade. High deductible plans have been here to stay for a while. I don't know that we have the magic answer, but there's a couple of areas that we focus on at UC Health. The first is really how we think about bills is, first it's what you expect to pay, then it's the actual act of paying it. So at UC Health, we've been for the last 3 or so years focusing on developing estimates, particularly in the self-service space. So we all know that price transparency has had all sorts of visibility, whether it's regulatory in the federal or state levels, but we have really been promoting price transparency and trying to be a leader in this area. And so we've been working on making estimates available to the patient through their app, our app, or we have a dedicated call center of specialists that can do a little bit more detailed information to a patient if they need. But we believe that the more transparency into what the patient will ultimately owe is the best value add for helping patients understand their bills. And then on the flip side, again, more in the self-service space, but we found tremendous success in allowing patients to set their own payment plan terms, whether it's, we have these minimum thresholds within a certain period of time, but we found that patients like to decide what amounts they're going to make for their monthly commitment. So we've given them all of that ability to do that. It's been tremendously successful. So I think we're definitely far from perfect, but we will continue to move down that self-service journey and continue to give more control to the patient through the app, through the desktop methods, through our customer service teams, and really just have more interactions and think about the different ways that patients want to connect to us, which has changed and evolved more into the technology space over time.
Candace, those are great insights. It reminds me of some work that Dr. Richard Thaler did. He won the Nobel Prize in 2017 about rational people want to be in control of their financial future. And it sounds like giving them those tools and those choices really is aligned with some of that more modern behavioral science insights of how to take those balances and get them forward.
Absolutely. And when you look at the industry outside of healthcare, you see companies like Afterpay and Klarna really taking hold, and it's really offering more flexibility for people to make the choice interest-free of paying it, not all at once, but installments. So, yeah.
Great insight. By the way, for our audience today, the questions, if you put them through the Q&A, that'll be a little more efficient for us. We can capture them in the chat, but Q&A would be our preference. Ray, insights on this topic?
Yeah, when I got here in 2019, I actually did an evaluation of the revenue cycle here, and we elected to provide or increase communication with our patients. We increased the patient billing cycle time frame. We redesigned our patient statements. We have 3 different systems going on here, so we actually went through and standardized the statements all into one form, so everything looked more familiar with patients and so they could better understand it. We also partnered with an early out vendor to increase our ability to actually reach out and talk to these patients to explore options for financial assistance. We implemented a prompt pay discount policy where we started giving more estimates out to our self-pay patients, giving them opportunity to pay up front through incentives. We also increased our payment plan terms for them, and we set up a online payment portal for our medical group. And this really helped improve our revenue through our self-pay patient population, all prior to COVID, of course, but since COVID, that's one area that struggled. But I think across the industry, we've seen that become to trickle through instead of good revenue coming in like we were hoping.
Well, it sounds like a strong foundation, and COVID is not supposed to last forever. Laura, any insights from your system?
On top of what others have mentioned, I think probably one of the biggest things we've been working on is certainly, patient estimation tools, and those being more self-service friendly, if you will, and really been focused on the accuracy of those of late, particularly with the pricing transparency, compliance deadlines and such. But in the uniqueness that we own our own health plan and are associated with our own health plan, they have their own upcoming compliance deadlines in 2021. So really looking to see how we can align with our own, health plan in particular, and use that as a basis, or jumping off tool with other payers, but really ensuring that our patients and our members that are, that they're seeing consistency across between our health plan and us, because that's always the caveat, right? All of us putting our pricing transparency, talk to your payer first, right? Well, since we have our own payer, it's really making sure that we're being consistent in that approach with, out-of-pocket responsibility, et cetera, and really hoping that can be kind of a strategic differentiator in our market, going forward. So thank you.
That's a great point, that strategic emphasis. Chris, how about the perspective from Kalispell?
Yeah, it really is aligned with all the great ideas and initiatives that I'm hearing from my counterparts here. This is an environment, with these high deductible health plans that are now omnipresent, and healthcare costs to the patient are continuing to increase. This new environment sort of labels the patient now as the payer. And that's really challenging because healthcare costs and expenses seem to be one of the most least understood things in any industry, among any industry. But we've really taken the step to, similar to others, sort of leverage price transparency. We have on our website a interactive price estimation tool for some shoppable services. And we really are proud of that because, and I'll speak to this a little bit more as we get into some of the other discussion, but it's interactive in the sense that it gives the patient control. And so it says, what is your deductible? What is your, what is your coverage? What is your, what can you put down? Things like that. And so what we're trying to do is by making it interactive, we're trying to sort of establish accountability in the patient base to understand their insurance plan, because there seems to be, it's not just in Kalispell, I would imagine, but there seems to be a tremendous gap in the knowledge regarding how insurance works. Sometimes I wonder if people really understand what they're signing up for, and then when they go to use it, the way it works is kind of a mystery. So by getting the, having that interactive tool, what we're hoping that does is it also forces a learning moment and education, and helps the consumer become more informed when it's time for open enrollment.
Thanks, Chris. No, those are great insights, and I appreciate how rich this discussion is. Connie, even though you're going last out of the 5 on this one, I suspect you've got some new material to add.
Well, certainly we're approaching a lot of the same types of things that everyone else spoke about. Certainly with our patients being children, their guarantors or their families tend to be younger, right? So we're really looking at how can we use text, how can we meet them where they are? But the biggest thing, and this is going to be a huge effort for us in the next year and a half or so. And it's interesting because people come to work at Phoenix Children's because they want to be a part of the mission. They care about the children, they care about the families, they want to have meaning in their work. And we talk a lot about being family focused, and we are. But that doesn't mean we've designed our revenue cycle processes around the impact on the family and their finances. So as we endeavor into this, going to the journey that we're going to embark upon about how do we redesign this, is really going to be around thinking about how does every decision we make in revenue cycle, how does that impact the family? So we've done things like prompt pay discounts. We've changed our self-pay pricing and our balance after insurance pricing to ensure that we're not charging families full bill charges, that we have other methods. So a lot of it for us at this point is a mindset. And we're looking forward to getting to where some of you have gotten in terms of your, being able to have patients set up their own payment plans and things like that. So.
I knew it would be rich still, Connie, and that's powerful in terms of that concept of a persona. And here I'm hearing you say the family is the persona of what do they need in order to have a great experience here, and that's powerful. So there's another part of this question that we wanted to dive into, and that is, what strategies have you done to help move folks from the bad debt classification into greater amounts of charity or community care? And what has been the impact of those strategies? And Laura, let's start with you on this one.
Sure. We actually at Presbyterian, we've been doing quite a bit of analysis and trying to leverage more of the social determinants of health data, really trying to ensure that our patients are not placed in bad debt when they honestly should be, charity care. That's a little bit difficult, as we all know, but we're trying to combine that demographic and social information, that you get with area deprivation indexes. And as many of you know, that's more census related information that identifies those areas that have less income, less education, et cetera. And we've actually been able to identify some opportunities there in terms of folks who are in, the bad debt category, who most likely would qualify for charity care. And I think the interesting part is we've looked at this is, we're talking both uninsured and underinsured. 83% of the folks, when you look at this, they have insurance, and we're not talking large, balances here either. These are less than $1,000 balances in many instances. But as we know here, especially here in New Mexico, those are probably folks making the decision of making a payment to the healthcare system or putting food on their table. And so we certainly respect those decisions, and our goal is to make sure that we're taking care of them. So some of the things we're doing is we're really trying to drive some improvements on our front end processes. How can we more quickly and accurately identify these patients? We're starting to collaborate with our physician clinics so that we can start that process, whether it's applying for Medicaid or other funding sources. We're starting that earlier on instead of waiting till they kind of get down the further path, if you will. And then we're also, looking at evaluating some of our charity care policies. We want to see if we should add the use of the area deprivation index information into that. And an example of that would be making an assumption based on that ADI data that maybe a specific zip code should be assumed to be charity care. And other things, but we're working through that still. We haven't made those changes yet, but we're getting closer and closer to it. And then I think also in our state, evaluating how we can get patients to help themselves. This is difficult here. We're in a rural state in many aspects of the state. People are rural and don't have the technology, the needed technology to either communicate or even, get on a computer, fill out an application, etc. So everything we're doing, whether it's, getting with them up front, getting out to see them, etc. Anything we can do to kick off those processes earlier and secure those accounts financially, and probably most importantly, give those folks, our patients, peace of mind. That's everything that we're trying to do.
Laura, do you feel like you're on the cutting edge in using some of that census data, or if you found others throughout the country that have begun to look at it that way as well?
I talk to peers across the country who are certainly, social determinants of health is relatively newer, if you will, in the revenue cycle lingo. I do think, we have a pretty advanced analytics organization within our company. So it's really, taking a lot of that data that typically you'd have a vendor possibly, doing your presumptive charity or some of those early analysis and marrying it up with that ADI information and being able to actually make some determinations and move, people from bad debt to charity. So I do feel like we're definitely out there on the forefront. I don't know if we're the cutting edge, but we're definitely using it to make decisions and make determination changes between bad debt and charity care.
No, very, very interesting. Candace or Ray, other insights from your organizations?
I can go first. I'm jealous. I want to do something more like Laura has, and I wish I had a really good, robust analytics team that could dig into some of the SDOH stuff, but I don't. One of the areas that my patient access team is actively looking into is we recognize we could do more, and we should do more in looking at the migration between bad debt to charity. And so we're actively working through what would a presumptive charity policy look like. And specifically for patients with catastrophic balances that are mainly in limited benefit policies or some of the meta shares, like the not real insurance plans, how we might be able to look into a specific catastrophic policy, since, we have, unfortunately, instances where patients qualify for financial assistance, but even those discounted bills are substantial and nobody could pay for those. So we're looking into this, recognizing we need to do more in this space.
Thanks. Ray?
And Scott, for us here at Wyoming, different angle. Since we're in the middle of an implementation with Banner, we are actively engaged in distributing their financial assistance policy across our system here in Wyoming, shooting for a March 1st go live. But that policy, very impressed with Banner, how they put that policy together. It's going to allow us to increase our federal poverty limit levels and also enhance our presumptive eligibility as well. So I'm really looking forward to that new policy for us here at Wyoming and for the communities that we serve.
With it being on the horizon there so quickly, you're going to have some good before and after data, and that'll be pretty intriguing.
Oh, absolutely. I am absolutely looking forward to that. Surely hoping to see a shift from our bad debt over to charity is where I am really hoping to see it.
Great. Connie, your perspectives?
Great. So I agree with you. I'm a little jealous of Laura. Fortunately, we do have a great analytics team, but really for this, again, we're starting with our foundation. So the foundation really is, we built out a revenue cycle mission and vision specific for revenue cycle. And a piece of that in becoming what we want to be, which is the premier Children's Hospital Revenue Cycle Organization. And one of the ways we said we're going to do this by is becoming the subject matter expert when it comes to financial resources for our families. So that means understanding internally what's available, understanding externally what's available, and finding ways to make those connections. We are very fortunate to have an extremely strong front-end patient access team. Actually, some of our strongest point of service or pre-service collections are coming from our pre-access team. So we focus early. Fortunately, we have a system to give patient estimates. And then we've got a strong financial counseling team as well. Also, just the basic blocking and tackling. We run eligibility to batch eligibility at a bunch of different points along the way to make sure that we're not missing insurance. And then this isn't necessarily getting people from bad debt to charity, but one of the things that we've recognized is sometimes our practices or issues with our practices during our process are potentially causing patients to go to collections. So we had a situation where we didn't have the correct contact information, and we found we had an issue. So one of the things we've really been trying to do is dive in every time we have an issue and figure out where that came from and try and resolve that issue. And the team has been amazing at doing that.
Connie, I think there's 0% chance of you ever getting bored.
We have a lot going on.
I'm glad you talked about the accuracy of that data. We're publishing a white paper on that, and it's so simple, right? It's the blocking and tackling. Do you have the right name, address, date of birth? Do you have an email address? And that's such valuable. I mean, that makes a difference in the experience as well as the collectability of that account.
Yeah. And there are nuances in the system, like we have a patient screen and we have a guarantor screen, right? So if a change gets made in the patient screen, doesn't flow to the guarantor screen, then we have an issue. So it really is diving in so deeply on every one of these issues that come up. And, you know, we know that we're going to make a difference as we continue that process.
Terrific. Chris, your thoughts?
Yeah, in the interest of time here, so much great stuff is said. Boy, it is hard going last, right? I don't want to repeat anything that anybody already said. Definitely jealous, like everybody else, of the fantastic work being done in New Mexico. You know, one of the things I noticed when I got here is we had an asset test in our charity policy. And so I removed that this year. And I think that's going to be huge. I know it might sound very simple, but that is going to qualify so many additional members of the community for our charity policy. And so I'm excited to see the impact of that. We also have a lot of work to do here related to increasing our self-pay discount. I think that we can do better. And I have a policy I'm ready to push that I'm expecting approval on, that I think will be received very well by the community, where we're going to enhance our self-pay discount. And then as well as implementing some really point of service cash collections sort of deposit matrix. This is probably a sentiment shared by Ray, I'm assuming, but in these rural communities, it's very uncomfortable for staff to ask for money. And so we have a lot of counseling and scripting and things going on that we're hoping will sort of increase that point of service collection, because I've been approached multiple times in the community here, very small community. And somebody said, hey man, I had $2,000 in my pocket ready to pay, but when I asked, you know, who to give it to, they said, don't worry, we'll send you a bill. Right. And it just drives me crazy. We use a self-pay, we use an early out vendor. So that person's bill went to an early out vendor, and then the letterhead came out with our name to that patient. And so there's a percentage collected by the vendor. So being able to provide that avenue for patients, I actually wrote down the quote, rational people want to be in control of their financial future, because I've been trying to make that point. It's amazing to see you would think, you know, people were worried about negative PR with policies related to asking for money up front. And it's been the opposite. It's people saying, finally, man, I was glad to make that payment and know I've contributed toward my bill. Because who knows where that money goes when they get their bill a month later, is it still there? So people want to pay their bills in a lot of instances, and we have to get better in Kalispell of giving them the opportunity. And I think we're well underway.
Chris, that's great insight. And despite having to go last, you put a lot of valuable insight there. Deb and Day, thank you both for getting your questions on the table. Deb, for those of our panelists that are willing to share this, what self-pay discounts are you offering for patients that have no insurance at all? And how do you manage that?
So we have a couple things. One is a prompt pay discount, and that's 50% if it's paid within the first 30 days from the initial statement. The other thing that we've done is to, again, re-look at how we determine what is owed. So rather than balance billing, we actually took a percentage of what we would have been reimbursed from Medicaid to try and get that to, what we believe is the right level of comparison compared to our insurance payers, so that we're not incentivizing patients not to use their insurance, but we're also not making it impossible for them to pay their bills.
Great. Candace?
And I can, yeah. So I don't have a number to share because we have many hospitals and unfortunately they're not all on the same fee schedule. But I would say that it varies, and Colorado State has a law that says patients, self-pay or uninsured patients, have to be able to access the best negotiated commercial rate. So that's certainly a way to go at it, is you can look at who of your negotiated payers has your best rate and extend those same discounts to your uninsured population.
Terrific. Any other insights on that one?
Yeah, this is Laura. From Presbyterian, ours is 30% from the, for the self-pay discount. And interestingly, here in New Mexico, there's a current bill in front of our legislature that would require us not to bill patients, uninsured patients, anything greater than the Medicare reimbursement rate going forward. So interesting to see if that takes hold in our legislative session and passes, but that's what we're looking at here.
Oregon, where I'm from, we're under a law now, under 200% of the federal poverty level, it is mandated to be free. 200 to 300 significant discount, 300 to 400 less, and then over 400 is when the patient's normal deductible and copay would kick in, which is about $105,000 a year for a family of four. One other question that came up in the Q&A is, with respect to those plans with really large deductibles, do you have any hardship rationale to make those deductibles a smaller amount?
So this is Chris. You know what? I'll jump in here because I'm actually really curious to hear some of the other panelists' answers. I've struggled with this one. The high deductible health plan, you want to do what's best for the patient. But in the interest of the individual, it can be dangerous sometimes because you have to consider the community at large that we serve, right? So if somebody has a $7,000 high deductible plan and they come in for a surgery that's $7,000, sure, we want to discount that, right? We want to make it payable for the patient. But if we do that, we just contributed and subsidized to their deductible, and now they have free healthcare for the rest of the year. Are we going to do that for Tom, who comes in tomorrow? And so you can't look at it on an individual basis. And the piece I've been really struggling with is, do I remove the policy where we have traditionally been discounting patient responsibility, copay even? Our patients became very wise. When I got here, there was a policy where if you paid at the counter, your copay of, let's say, $30, it was $30. But if you didn't pay it and you said you don't want to, we'd send you a bill and offer a 15% discount on that $30. And so patients we essentially incentivized the entire valley to not pay when they came for their appointment. So I'm really curious to hear what other panelists say they're doing in this space, because I really do want to emulate it and do the right thing. And I want to be in line with some of the larger systems that I respect so much that are here.
No, Chris, great insight in terms of, what are we really incentivizing? Other thoughts on that, to Chris's point?
I
Candace?
can give it a go. So we used to also have prompt pay discounts, and we took it away for that very reason, is people get really comfortable with, paying exactly what they would owe less the prompt pay discount. So we took it away, and we, right, wrong, or indifferent, maybe I have the same problem you do, but we basically said financial assistance policy applies for all medically necessary services. And there's specific exclusions of where financial assistance doesn't apply. But we basically, we've taken an approach that it's for uninsured and underinsured. And so, in some instances, yeah, we have done financial assistance, applications pre-surgery. And if they are approved, then they get those discounted amounts or whatnot. But that's unfortunately the only way we could make sure that it was being administered fairly and consistently.
The fairness theme is important. Other insights on this one?
Yeah, and that, Scott, historically, when I got here, we used to give a 20% discount for patients in lieu of a payment plan. We do that during tax time, and we did that for years. And the community developed a habit of asking us year after year about that discount program if we were going to start it back up for the next tax period time. And it was always a year to year, as long as we got approval from our compliance officer, that we would do that. Now, this last year, we actually had stepped that up and did a 40% discount in lieu of a payment plan for payment in full for patients. But currently right now, Scott, we're not offering anything like that for any of our insured patients. We point them in the direction of financial assistance now is the direction that we have moved to, just because we don't want to set that precedence of getting the services cheaper. If you got the insurance, patients really need to understand their responsibility more. And we got the financial assistance policy, and it's there for the patients who truly need it.
That's a great perspective. The community remembers. That might be the quote of the day. Appreciate all your insights on that. Let's jump into our next big topic, which is a big topic, price transparency. And we know we just all went through a recent legislative requirement, and we know we've got more legislative requirements as we go further out in time. There's really two perspectives to price transparency that I think are important to talk about today. One is strategic and one is practical. So let's start with the strategic question first. And so the question is this: what are the strategic issues that providers should consider in general? And then what did your organization do specifically, and how to apply the price transparency rules? And Candace, let's start with you on this one.
Oh, I have a lot of strong opinions about this topic. How much time do you have? I look, and I have talked to a lot of peers across the country, and I would say that there is not one revenue cycle answer consistently everywhere. Different people are in different places with this. I've actually heard some organizations who think that the price transparency mandates are just too difficult to administer, and so they've made the conscientious decision not to do it. And to those organizations, I cringe a little bit, because I think that as a provider community, we've not been the most successful at articulating the factors that make this whole exercise so complex. We rely on a complex set of codes. We make a clinician or expect them to understand what these codes mean. And then, there may or may not be ancillary charges, implants, pharmacy, radiology, et cetera, et cetera. And then you may or may not be contending with an internal or external physician group. And so from a patient's perspective, when they get a quote, it's a very different experience from, all of our, for each of our locations, how comprehensive that quote is. And so to the end consumer that is non-healthcare layperson, this is very nebulous. It seems quasi shady for health systems to not be much more open and transparent. And I think that's the issue that we're facing today. So I think we as a provider community need to recognize that this is far more difficult to the end consumer than it needs to be, that price transparency is here to stay. It's not going away, and we should and can do better. And I don't want non-healthcare experts telling us how to meet requirements. I want us as experts to help set the stage of what it needs to be. Now, all of that said, it is incredibly complex, and we're a bigger health system, and we candidly struggle with this because at the heart of every estimate is accuracy. And just a simple example of, a provider that orders a stress test, some people may not realize that a simple stress test, there may be an 80+% chance that provider wants a treadmill test that accompanies that stress test. So there's so many different factors that go into accurate estimates that we need to make better use of analytics. We need to make this more of a science than the art that it is. And that is strategically where UC Health is trying to position itself. Again, we want to be a leader in this. We know we can do better. We've dipped our toes in the self-service space. We're going to be focusing and going all in on accuracy and doubling down those efforts over the next few years so we can start to make this much more seamless to both the patients and the providers.
Thanks, Candace. We're getting so many great quotes today out of this session. I love it. Ray, what's your thoughts on the strategic part of price transparency?
Now, Candace very well said. The importance about doing what we can to provide patients a clear view into their cost of care. To date, I don't know of anybody that's been very effective. We here at Wyoming Medical Center, historically, we haven't been very effective at this because doing an estimate based off the disparate systems we have has proven to be very difficult. Early on stages in this, Scott, we determined that there's no way we could do this in-house on ourselves just because of how complicated it was. So from a strategic point, we determined that we needed to partner with a vendor to help us meet this regulation requirements on time and effectively to ensure that we weren't getting the $300 daily fine that would have been imposed. And on top of that, we did not want CMS to publicize our penalty or publicize our noncompliance for not meeting that regulation. So it was really important to us to meet this, and strategically we went with the vendor to meet this regulation for us.
No, appreciate that so much. And we'll get to the other part in just a minute on the practical piece. So much like that is. Chris, your thoughts on the strategic importance of this?
Yeah, it's extremely well said by both panelists. I have a lot to say on this topic as well, and we could probably spend the entire, seminar sort of discussing this. But I agree with everything that the other panelists have said. I will note that the way we tackled specifically the fact that so much more can take place in a visit from an initial quote is I bring up that tool that we leverage through transparency, where the estimator is interactive for the patient to look at, and when they get to a point where it's ready to provide the quote, we use the vendor that we also use for our CDM alignment and studies. So they have 5 years of our data for every single charge we've ever run. And what they did is they built in the probability of additional services being coupled with that service that the patient is going to have done. So let's say you're going in there for just a scan or an image. Well, 90% of the time, this charge also ends up on that claim, and it's using history. So the patient can say, if this happens 90% of the time, I'm probably going to want to factor that additional cost on top of my quote. So it's kind of trying to just empower them and, again, educate. I mean, it's like a passive form of education where they're not in a classroom. They don't realize that they're being taught, but this is the way healthcare works, that all these things could potentially take place in addition to just the service you thought you were going to receive. So that tool is huge. But it's also so interesting, transparency, because if we go back to the CDM publishing or the publishing of our charge masters from, you know, a little over a year ago, I think there was a study that found, you know, that data means nothing to the consumer. It doesn't even mean anything to me, to be completely honest with you. And I think it was like 90% of the users, 97% of the users were institutional. And so, you know, but when we get into the more practical piece here is the follow-up. The truth is, in the spirit of the law, I look at competitors' tools on their website, and I'm making sure that I'm in line with them. I want to be competitive, and everybody has probably a different policy for how they set charges. And I want to make sure that an Echo here is the same thing as an Echo 3 hours over the mountain in, you know, Great Falls, Montana. And so I have been checking those websites for those who have them. I don't think a lot of systems, I don't believe, are complying yet with it, which is their prerogative. That's fine. But transparency, I think, I don't want to sound like I'm sour on the idea. I do think that to follow with what Candace said, I want to embrace it. Instead of trying to simply just comply, I'd rather go above and beyond and be an owner in this workspace, because it is in the spirit of what's best for the community.
No, I appreciate that perspective a lot, Chris. Connie, and then Laura, your thoughts on the big picture strategy piece of price transparency.
Yes, so we also made the decision to comply and to use a vendor. We combined it with CDM and pricing review, so we put those things all together. For those that are deciding what they're going to do and maybe aren't complying, I mean, it is, you can see why it might be tempting not to comply and pay the $300 a day, because we certainly have spent more than a year of $300 a day in building it out. That said, I think we inherently believe it's the right thing to do. Not just for the requirement, but because we want transparency. That said, the complexity has been amazing. It's taken, I honestly don't know that we would have gotten there on our own without the, not just the analytic support, but the expertise from our vendor. So it's been a journey.
Great points. Thank you, Laura.
Yeah, I think it's interesting. I was in a meeting earlier today that someone stated, I think 30% of the healthcare organizations out there have decided not to comply with the regulations, which is interesting to me. I'm not sure I want to be on that side of the fence, but again, I do think it introduces, I think there's a lot of reasons why people haven't done that. And I think part of that is just the general conversation that's been here about, overall usefulness, right? I mean, these are on your websites, and I know we're monitoring, who's accessing, but how often it's being accessed. And when you think about those machine readable files, they don't really tell anybody a whole lot. I mean, even if you have the expertise we have to look at them, it doesn't tell you a whole lot. So it really gets back to, those patient estimation tools and making those effective and accurate. And I think that's, where I think a lot of systems want to put their efforts. I think strategically for us, one consideration we had to make was, that we have, our own health plan, was just, what our negotiated rates are with our own health plan versus what others around us may have negotiated with our health plan, and the transparency around that in terms of, any perceived advantage folks might think that we have in that situation or that relationship. So that was definitely something that we had to take into consideration and think about and really consider the optics of and do quite a bit of analysis around to see what that looked like. So
Chris and Laura, you both brought up this point of there's a competitive element to this. Now more information is available. I'm curious, is each of your organizations who did implement, as you thought about it, did it actually change your view of how you wanted to compete in the market or how you viewed yourself in the market strategically? And Connie, let's start with you on that one.
So I don't know that it changed our view, but the whole idea that it's going to be out there for people to see um, made us have, I think, deeper discussions, more clarity, and we got to the point where we said, okay, for these specific services, this is where we want to be in relationship to our peers. Then we said, okay, who are our peers for this? So, you know, we priced ourselves specifically at a range for our primary care services, which was very different, and compared that locally. And, you know, through our vendor, we were able to compare not just the big systems, but, you know, really compare at a provider level. Then we said, well, for our tertiary and quaternary services, you know, we don't want to be comparing necessarily locally. We should be comparing to other children's hospitals and the specific other children's hospitals. And we actually did then use those types of discussions and the data that we had to decide where we were going to price very specific services. And it got down to a real, very detailed level for how we were deciding on our pricing. The other component of it was, and just one of the things I think we wanted to talk about here was kind of the nuances and the issues, you know, so we implemented it because of the requirements, right? So like on our shoppable services, patient estimator tool, you know, we've got like the definition of a DRG, but we know that most patients, I mean, how do they get their DRG? Right. So we know that some of the things that we did to meet the requirement may actually confuse people more than it will help people. So that's, I think, is back to the point we were talking about before, and especially you were talking about, Candace, trying to get ahead of this as an industry so that we're not just reacting, we're driving this. Mm-hmm. So. But it really did help us really hone in on where we wanted our pricing to be competitively.
Sounds like these kinds of discussions are going to bring perhaps some innovation as well as how we position ourselves. Chris, you talked about looking at your colleagues in Billings. Did it change the way you looked at yourself at all?
Yeah, absolutely. Look, I mean, there's no secret. A free market is predicated on competition, right? I mean, we need to know what something costs in order to properly align ourselves with some sort of standard. I mean, without a standard, I mean, is our logic correct on how we're setting prices? Is our margin that we're aiming for correct? I mean, is it, you know, on top of all of that, even each demographic is different. I mean, if an overwhelming amount of our services are in one service line or one service area, you know, you need to make sure you're competitive. You need to make sure you're being a steward of your financial resources. I mean, at the end of the day, it's not about making money to line pockets. It's about making sure you're sustainable and serving your community and expanding access points and you know, following the mission of whatever it may be that your system, where we probably all want the same thing for our systems. And by opening up the door to see each other's prices, I just mentioned it. I mean, I looked at an Echo over the hill and I said, yikes, I want to lower my Echo. That's a good thing. That in the spirit of the law, I think that's what we're trying to do, is make everything a little bit more transparent. Now, the only problem with some of this stuff and where you run into trouble is everybody always says, hey, when I went and got my car, I didn't have to pay for the steering wheel and the brakes. I just bought a car. Well, healthcare is not buying a car, right? And it's the worst comparison you could possibly make. And so it's an industry unto itself, and it's entirely unique. And we need to get better and, you know, get out of the ice age of how we, you know, are transparent and how we charge. At the end of the day, I think hospital margins just continually get squeezed. There's other players in this healthcare industry. And so the three-legged stool is essentially pharma, insurance, and providers, right? Well, I think if we, you know, our information is public and we're saying this is what we charge, this is our margin, we're trying to pay physicians, hopefully what will come of that is there will be pressure on the other legs of the stool. And hopefully we get to a point where it's affordable, it's sustainable, and, you know, regulation doesn't a little sour here, but regulation doesn't seem to just target hospitals. So I don't think we're going down this road. It's not going away, as Candace said. So let's embrace it. Let's move forward. Let's be transparent and let's educate. And I think by going down that road, we have nothing to lose.
No, great points. And in the sake of time, and to make sure we cover some other areas, let's go ahead and switch over to the practical side. And Laura, what are some of the tools or processes, either best practices or, you know, we're being vulnerable so far, lessons learned in terms of getting to actually put the tool out there and populate it with accurate data?
Yeah, and so we did ours internally, and so you know, we definitely were able to leverage our analytics organization again to help us with the development of all the data and such. But I think that you know, from a practical perspective, this made us really look at more from a, not so much just getting the data and the files out there, that part's, you know, kind of check the box. Yeah, I did it. But really focusing on the patient estimate tools in that process, and how could we, you know, how could we improve our communications? How could we make sure our communications were succinct and consistent across all the multiple platforms that people might access Presbyterian, whether it's our websites, on their phones, etc. And really focused on, you know, self-service tools, streamlining that, making sure we had accuracy. And so one of the things where, you know, I apologize, I forget which panelist was saying they were referencing, you know, their 5 years of data through their vendor and such. You know, we were doing similar things through our EMR, but then how do we tie that to our actual, you know, contracting language and such? And so really focused on marrying that up so that a patient could actually pick, you know, the plan that they had within a specific, you know, payer and get, you know, pretty accurate information for them. The part that's a struggle still is, you know, obviously that connectivity on knowing what out of pocket they've met so far. You know, the whole key of this is so patients can figure out what their out of pocket is going to be. And so, you know, that's still the gap, I think. And for us to figure out is, you know, getting that insurance information as well. And where is a patient at relative to that, and plugging it into those estimation tools.
Mm-hmm. Good insights. Ray, you talked about using the help of a vendor. Any other insights on the process itself, lessons learned that we should be sharing?
It definitely was a process. There was a lot of back and forth with the vendor to make sure we were staying on track, to ensure we met our deadline to get it up and running. We actually ended up using two different vendors. One vendor created our machine readable file and our shoppable services file. Then the second vendor, we used them to actually post it with links on our website. So those files were readable and downloadable for the patient. It was, needless to say, it was a headache at times. I had a great team under me that continued to stay on the vendor to make sure they were on it. We worked closely with our finance department because we did, even though the vendor was doing the work, we did our own double self-check to make sure the prices, everything looked accurate. Because at the end of the day, it's our name out there, it's our prices out there. We needed to make sure everything was accurate. So combination of my team and our finance team, we really were able to meet the requirement and get it out there. And I was pretty satisfied with the work that they all did, but it was definitely a process.
A huge process, indeed. Candace, your insights on that?
So as far as, this recent regulation required us to do the shoppable services, or excuse me, the shoppable estimates, the 300 most common shoppable services, and then the negotiated rates. So like others, we engaged a vendor to help us have all of that information available. I will say that we put lots and lots of disclaimers on it because we wanted to redirect patients to our estimation tool, because we're an Epic EMR shop. So we spent a lot of time and blood, sweat, and tears developing our system and building a lot of templates for people to come and look at, you know, joint replacements at each of our sites. And so we not only take your information, but we're running it through real-time eligibility. So it really is custom tailored to, you know, Candace Hoshi's benefit, based on, her insurance plan, she could go to any one of our UC Health sites, and I could easily see, if my out-of-pocket varies, or maybe I just have the same deductible amount and it's the same amount everywhere. So we've spent a lot of time developing that, and so we put a lot of disclaimers on our check the box versions, so to speak, that we've gotten a vendor to help us with.
Terrific. Connie, your insights.
Yeah, I mean, I think the time that this really hit me was when we were on a call and the vendor was talking about, this machine readable file has millions of lines of data. And I thought, oh my gosh, it really just hit home how complex and kind of crazy this all is. I think we got there. Like you guys are talking about, we have our shoppable services, patient estimator tool, but same thing, like really trying to direct them to our financial counselors to get, hopefully a more detailed and more accurate estimate. Did a lot of work on the disclaimers and, how do we make sure that we're being transparent and that, we're getting the best that we can for an estimate, but really trying to make sure people know that we need more information before we can get it. So, so it's quite a process.
It is an amazing thing when you think about the volume of data that each of you have had to put out there. Chris, you talked about the 5-year history and that probability, which really intrigued me. Other insights you have from getting this live?
Oh, Scott, I've talked about quite a bit, haven't I? I don't have much more to add other than from a practical standpoint, it really is about owning it and trying to encourage the consumer, the patient to use the product instead of just a bunch of us industry, insiders using each other's product to try to, compete. And so I love the idea of, again, I think Candace said it, but steer them away from, this extremely confusing, downloadable, machine readable file and use our estimator. Get your own estimate using your own information, and then give us a call and we'll provide you an estimate as well. And so we actually have 2 products. We have an internal product that we use to provide estimates. And then we have our transparency product that essentially leads to us being in compliance with transparency rules. And so we need to make sure that they're both saying the same thing. So that's been a very big challenge because it's not the same vendor that created each. There's a story there, but so just getting individuals to use it and hopefully, from the practical side of things, I hope it's useful. And so I think, to be honest, I think we're a little too early into it to really know yet. But if we just continue to embrace this, it's not going away. I think we'll make, it'll be really interesting to see where we are in 5 years.
Terrific. No, that's a great piece as well. And I'm more interested in the strategic impact this will have on that 5-year time horizon. And with the time that we have, let's change the topic over to work from home. If you could quickly give, where is your system at on work from home? And post-pandemic, are you expecting to be in a hybrid or bring everybody back to the office? And then if you've got something that would be especially useful to share on how you've improved morale if you are in that work from home perspective today, where people are a little bit disconnected. And Ray, let's start with the frontier states. You and Chris first.
All right. Well, Scott, right now we're not seeing a lot of cases. We saw a lot of cases back in November, but right now we're not. So we actually don't have any staff working from home. Earlier in 2020, we had a couple of employees in Revenue Cycle that we sent home. They since have come back several months ago. So currently right now, what I've done is actually split my billing teams. They were in a very tight space, close quarters. And back in October, November timeframe, we actually split them relocated one team altogether, spread them all out, gave them some social distancing. Right after we did that, the cases I had of COVID-19 within my own team dropped pretty quickly to the point where we really weren't seeing much of it anymore within my own team. And that's been successful for us. But right now, we don't have any of my staff that are working from home right now.
Got
Yeah.
it. Thanks. I've got to unmute. Chris.
Yeah, I think Ray and I are probably going to be the only two here in alignment with this. Look, we're all welcome to our opinions. The state of Montana really did not shut down, is the truth. I guess I worked from home for a few weeks in April, and then it was back to business. We really aren't working from home. I'm at home right now because I wanted to call into this panel from home. My office would not provide a nice backdrop like this. So, you know, did we suffer from doing that as a state? I've had COVID. Everybody I know's had it. So we're working on that herd immunity out here. And I think today our governor just lifted our mask mandate. So, you know, fortunately, I will say, similar to Ray, we had some open space. We're extremely lucky that we had some real estate that wasn't being used. So we did spread out. And that's kind of, you know, that helped. If somebody, we had a very strict policy from our OC health perspective, our occupational health team. If you were exposed or even concerned, there was a 14-day mandate where you couldn't come into the office. But, you know, there was a lot of questions about, well, are you going to buy me a computer? Here's this monitor I just found, you know, who do I charge it to? And so it raised a lot of, we're a tiny little system up here. And, you know, we didn't really do much work from home. And I love it. I'll tell you, I know that some of the other panelists are going to share some pretty impressive stuff, especially coming out of Presbyterian, I believe. But I think it's the way of the future. I don't know if you necessarily have to put on a suit and tie every day and walk into an office, maybe half the time. I think it's going to change the future and the state of things and how we, you know, commute to work or the environment in which we work, but not too much of it out here.
You know, we have so much diversity in HFMA and in the various communities, and it was refreshing to hear that. And indeed, let's go with you, Laura, next, because I know the Presbyterian story is indeed very different than what we just heard.
Yeah, we're quite different than Montana. New Mexico is, probably many of you know, has been one of the most locked down restrictive states in the country since the beginning of the pandemic. A lot of that is because of, you know, we have a significant elderly population, but we also have a lot of at-risk populations and such. And so, and a lot of our cultures here, you know, where you have multiple generations living in a single home. So anyways, we've been locked down since the beginning. And as, you know, Presbyterian, you know, we're one of the largest employers here in the state of New Mexico. And so we actually sent from our headquarters, we have about almost 3,000 people in our headquarters here in Albuquerque. Every single one of them was sent home within a week's time period in March of 2020. That entire workforce remains remote today. There's probably only about 50 people that are on site on any given day in our headquarters. And the plan is to remain that way at least until July of this year. But to be honest with you, as the conversations continue, it may be for the remainder of 2021. And part of that is just, you know, where you guys, Chris and Ray, you talked about having space. You can imagine, you know, so close to 3,000 people in a building. Space is tight, social distancing is difficult. And so we really feel like as an organization, we need to have enough folks, you know, vaccinated before we can go back. The other part of that is really evaluating what operations can remain remote. And I will tell you, as the leader for the revenue cycle, our revenue cycle operations is one of those areas that we're evaluating, you know, leaving remote on a permanent basis. We've seen improved productivity. We've seen, you know, a high satisfaction level from the staff. They enjoy the flexibility of the work hours, you know, more ability to balance with their personal commitments at home, et cetera. And I kind of find that surprising and think it will only improve because, you know, we are one of those states where the students have not returned to the classroom and most likely will not for this school year for the public schools. And so you're dealing with people who have, you know, you're a parent at home, you're working at home, and your kids are trying to go to school online. So there's a lot going on. But despite that, we've seen productivity increases, and folks have been really pleased thus far with working at home.
That's an impressive story. Candace, where did your system end up on this?
Well, if your job could be done from home, we sent you there within the first 3 days. We shut down as a health system. So, you know, Colorado probably started to pick up earlier in March. Probably maybe the middle to like the week of the 20th sounds familiar to me. We sent everyone home, and then we deployed over 500 clinics on telehealth within 3 calendar days. So that alone, I think, is an amazing feat. We had financial counselors calling patients. You know, it was, we had a really good stockpile of PPE, so that certainly wasn't the sole consideration, but of course, we had to preserve it and keep employees safe and really make sure we limited the number of people in the patient room. So we, our patient-facing staff have since gone back to direct patient care. Our administrative staff are still very much at home, and they're all listening to this, so I have to be a little bit careful. Let's say that we're thoughtfully having these conversations right now. I am very much sold on the fact that they have been highly productive. I've seen some of the most incredible metrics I've ever seen, and I've been here almost 2 decades. So I hear this pretty often from my colleagues and probably from all of our panelists here, but some of the best foot forward was certainly seen in the last year from all of our people, from not just the patient bedside, but all the way to the back end rev cycle people. So I am not of the illusion that we're going to go back to exactly pre-pandemic ways, but we have to balance the needs of the business. I run a corporate function that is accountable to a lot of different regional needs. So we have to be available for those needs, but I'm pretty sure there's a way to balance that without being completely at home or completely in the office. And those are the thoughtful conversations I like to have.
I love how you frame that. And it is interesting how adversity can bring out the best in us. Why does it take adversity? But those are powerful metrics that you shared. And Connie, you were nodding your head very much in agreement. I think you've got some great things to share.
So I wasn't there at the time, but same kind of story. Deployed everybody who could possibly work from home within a week, started up telemedicine, or telehealth. They did an amazing job. Unfortunately, we don't have great systems to be able to track productivity in the way you guys are talking about. But what I can say is that we believe productivity is at least as good as it was before. And our people like it for the most part. Our organization right now is in the process of looking at our long-term plans. Our short and midterm plans are to keep everybody home that can be home. And then what they're working on now and what is getting to the details that we hadn't had to address during COVID. So things like childcare. Like, are we going to require that someone who is working at home have childcare during the hours that they're working? Those equipment, like, what is our policy going to be? Are we going to supply it? Are we going to give them a stipend? How do we make sure that people have what they really need to do the job? Like, for most of our reps, it's hard not to do the work that they do without dual monitors and a great internet connection. So we're working through some of those types of things now as we plan for what the vision will be for the future, but it will be, working from home will be a large part of it going forward.
And I appreciate those insights, and that lack of connectivity on the internet is important You know, it's important from a telehealth, it's important from an employee standpoint. So you're right, it's never 100% one way or the other. All right, we're going to move into our last three questions, which are a little more personal in nature. This first one is just a few words. What do you see as the biggest challenge for your revenue cycle in 2021? Candace.
Continuing down the price transparency journey and meeting all of the requirements of the Appropriations Act. We just got a pretty heavy hand laid out for all of us. So meeting those requirements by January 2022 will be key.
Thank you. Chris.
I would definitely echo that sentiment. As we have a lot of work personally, this one is really more applicable. It's not a very general statement. It's more applicable to what we're trying to do here in Kalispell. But as we try to repair sort of our relationship with our community and lower prices and get things back to a more competitive environment, transparency certainly adds more transparency into charges, which I don't think are very well understood across the industry among certainly the lay people. And so, fighting that battle, I think that there's a good result there at the end of the day, but at the end of all of this, but it's going to be challenging.
Thank you. Connie, who I'm not seeing on the screen anymore.
She might be coming back in, Scott.
All right, Laura, let's have you go next.
Sure. Definitely the pricing transparency, but I would say, just trying to unravel the systems and such from COVID and the PHE as hopefully we come out on the other end of this. I know we've all modified a lot to make current, billing and such work. But probably the biggest thing I think about is just providing, a lot of nourishment and motivation for our teams. Teams are tired. People are tired. I know our rev cycle here in at Presbyterian, there's a lot of very tenured folks, and we're seeing a lot of retirements, and that's a lot of, expertise heading out the door. So they're great people that are on these teams, and we want to keep them. And so I think it's a challenge for the leadership teams to figure out, it's been a long year. So how do you keep those folks motivated and still wanting to have a career in healthcare revenue cycle?
Great insight. Thank you. Ray.
Yeah, for us here, price transparency is still going to be a focus for us, but our biggest focus for the next year to 18 months, it's our integration with Banner. It's going to take up a lot of our time as we look to fully integrate our revenue cycle and our system into the Banner family.
Thank you, Ray. Connie, I know you've got a lot of things to choose from, but what do you see as the biggest issue facing your rev cycle this year?
Yeah, I mean, we do have a lot going on, but really upping our game in the financial care for our families is going to be our top priority.
Got it. Thank you. Next question is, what accomplishment, either for you or your team, were you most proud of for 2020? Chris, let's start with you.
Yeah, sure. So one that I'm so proud of is this might make some chuckle, but we actually found a physician who was interested in revenue cycle and how it works and how denials work, and she has been absolutely amazing. I was just able to integrate her along with revenue cycle. So we have a medical director that partners with me in revenue cycle, and we're bridging that gap between clinical operations and sort of administration, which have always been very difficult to bridge that gap. So the education from denials, what we're finding, all of our data, we're getting that back into the clinical stream of things, and getting that information out there. And so far, so good. It's only been a few months, but wow, have we seen some big gains there.
I think you have just perhaps made some of the participants jealous of you now. So what a great win. Connie.
Yeah, I think I'm proudest of the way the team has addressed adversity. It's been COVID, it's been multiple issues. Sometimes we talk about, like, if you pick up a piece of paper, you find something under it. But they are an amazing team, and every day are doing really amazing things.
That's terrific. Laura.
Well, clearly our pricing transparency, especially since we did it all internally and didn't leverage any external vendors. So that was a huge lift for us organizationally, and for some specific individuals it was an incredible lift. I think outside of that, I would say just our ability to maintain focus on, our revenue cycle core functions and our metrics while, successfully responding to all the different demands of the pandemic, and not letting that get us off course. So I'm really proud of the teams and the work that they've done.
That's great. Thank you. Ray.
Yeah, for us, I'm actually going to echo Chris. Denials was a big success for us this year. We were able to improve our tracking and performance. Specifically, we were able to partner with our case managers, one of our providers, one of our doctors, in improving our inpatient-only procedures and also our inpatient criteria not met. Those denials, we really made some significant improvements on those this last year.
Terrific. Candace.
Gosh, I am proud of so many things. I'm proud of our organization that kept everybody whole throughout, right at the onset of this pandemic. We certainly had people on the bench and really wanted to protect their pay as we were all just trying to navigate all of the uncertainty. And then, of course, my team. It's such a cliche, but when an organization puts forward, their commitment to make sure that they protect your livelihoods, it really gives people a little bit of an inner strength and motivation to do something in return. And I feel so proud that we have not just the anecdotal accomplishments, but the actual metrics to support that. We've had some of our best performance this year under the toughest of times, and they have gotten a lot of our corporate board acknowledgments as a result of that, which is a tremendous feat if you know board members.
Thanks, Candace, and thanks everyone on that. I think it's great to be grateful. I think it's an integral part of living a rich and full life. Let's end on an even higher note. What inspires you and gives you hope for 2021? Connie, let's start with you.
Yeah, it's hard to work in a children's hospital and not be inspired by the children and families that come there every day. So I think for all of us, that's the reason we get up in the morning. That's what keeps us going. And, they'll stay our inspiration for 2021.
Great thought. Thank you. Laura.
Yeah, clearly our patients always are, but I think about, we're emerging from a once in a lifetime event. At least I think we all hope and pray it is a once in a lifetime event. But the teamwork, the collaboration, flexibility, agility, support, grace and kindness that folks have shown each other, the support that they've given each other, just that I've seen that demonstrated on a daily basis. And I truly believe that will forever change kind of the team and individual relationships within organizations for the better. So I think it's been a really hard time, but it's just been a really inspiring time too, to watch all these people, embrace what needs to get done and understand we're going to make mistakes and still be successful.
I love that. Ray.
For me, 2021, it's our ability that's coming our way through our affiliation with Banner. I know I've mentioned it several times now, but it truly is going to enhance our ability to serve our communities, give back. My staff's excited. I'm excited about it. It's something to really look forward to finally have more of the tools we need to effectively manage our revenue cycle, the AR. That's what's giving me hope and excitement for 2021 is all of the new stuff coming our way and our ability to do better.
Mm-hmm. Terrific. Thank you. Candace.
My comments are pretty similar to Laura's. My team inspires me. Every time I think this job is a little bit hard or I have a, not as great day, somebody says something creative or tells me about a problem they've solved on their own. And it really just brightens me up that we have a really highly skilled team of people that are really caring towards this organization about what we are here to do. And so it just keeps me going every day.
Terrific. Thank you. Chris.
Yeah, look, everything about 2021 inspires me. Being able to just look forward and get out of 2020. I mean, But again, echoing the sentiment of others on here, other panelists, our system just did such an amazing job, despite maybe the state not, locking down as much as you would prefer, like in New Mexico. We were just, I don't think we had a single outbreak in terms of a large outbreak at the hospital. We took every precaution that we thought we could, given, cybersecurity threats and things like that from working at home. We came together, we fought, we opened an alternative care facility that was ready to go, that had 100 beds, as it was a ward, ready to take on all comers from all states. I mean, the level of preparedness, the effort, everything was just, to look back on it in retrospect gives me a little bit of goosebumps. And I know that we are poised for a great year, and hey, maybe even a brand revamp.
There you go. Thank you so much. Well, what inspires me, first of all, is all the participants here today. Thank you for showing up. Thank you for making an investment in your career. Thank you for making an investment in HFMA and building relationships and finding ways to be the best version of yourself that you can be. I'm also inspired by our 5 panelists today. Each of you, I'm so appreciative, because I know how tight each of your schedules are and the investment that you made in order to share some really valuable insights with the rest of the Region 10 HFMA family. So I'm so grateful for you and what you've done. And that makes me have faith in our humanity and in the great calling that's on each of us to serve our communities with fantastic healthcare at reasonable prices.